Ladies and gentlemen, it's a pleasure to be here. My case is unsolved, but I would like you to help me to solve it, maybe, and it's not ended yet. So I saw my case for the last time 2 days ago, and that will be included in this series. So it starts in 2016. It's a 62-year-old farmer, and he was at that time diagnosed with an ANCA-associated vasculitis with renal failure. And he was treated with cyclophosphamide and steroids. And in October, he started to complain about his vision. At that time, he went to the ophthalmologist, and as somebody who lives far away from the city, they usually don't come so very fast to the ophthalmologist. And the situation looked like this. What will you say?
Anyone from the audience?
You're all thinking, no, well, this must be too simple.
Microphone to give a suggestion.
John, if you want to come up to the... I can't quite hear you from here, sorry.
You're pointing to the road spot, sir.
Yeah, that's what I want.
It
doesn't look like really occlusion because they're white size in the hemorrhages. So
nice observation. And the venous caliber in the context of that as well.
All right. It was at that time in another hospital diagnosed, with some suspicion of a CRVO, central retinal vein occlusion, and it was treated accordingly with bevacizumab monthly. And almost half year later, we saw him in Rotterdam, and this was the angiogram that was made in the referral hospital. So very slow fill of the retinal artery and veins, but no signs of vasculitis. They also looked for vasculitis because he was known with the ANCA-associated vasculitis.
So there seemed to be a perfusion issue.
On the earlier frames, was there patchy choroidal filling as well? Or was there patchy choroidal filling on earlier frames? Or a watershed on the vertical? Because
in the early frames there was, yes.
Okay.
Yeah. But the arm retina time was 14 seconds. So there was also a duplex done, but there were no abnormalities. And then he came to Rotterdam, and we saw this fluorescein angiogram starting. That was a half year later, under Avastin, monthly. Maybe I just want to show you this because it's so beautiful, but... And this is these are the late frames. So the left eye was completely normal, with normal vision, and the right eye was almost blind. What would you do?
Hans, can I ask you, when somebody who's ANCA positive with this kind of perfusion, does he have any orbital signs or any sinus symptoms? So I would image his orbit for sure, and I would check his sinuses, because sometimes you can have, with GPA or ANCA-associated disease, masses in the orbit or the sinuses that can compromise flow.
No, we did not, but there were no images made at that time. There was no suspicion of that. So, well, we were confronted with this situation, so we decided to treat him further and do a PRP, and in the end we had to do a cryotherapy, and the eye went blind. All systemic treatment was stopped and renal function stabilized. And then 6 years later, this is 6 years later, his left eye started. And his renal function was stable without therapy at that time. and his visual acuity went down to 20/30, so 0.6. And this was the image. It looks very much to one of the previous dogs. What do you think now? This is in May 2023. Is this a central retinal vein occlusion? He was not hypertensive.
Can you use the microphone, please?
Excuse me.
So if you go to the microphone, but from what I've heard, you said Purcher-like changes, did you say? With paravascular sparing. So I think the suggestion was Purcher-like changes with paravascular sparing, if I
Okay.
quoted you correctly.
Okay, okay. Shall we have a look at the angiogram? Here we go. So here the arm retina time was also around 14 seconds. And this is the late frame of this eye.
Was there a family history?
No. No.
Because we have the TREX mutation disease in the Netherlands.
Excuse me.
So
did we-
I think you said the filling is, the choroidal filling is not homogeneous? Yeah. So the choroidal filling is not homogeneous, but it's not horrifically patchily delayed. And 14 seconds depend. I mean, it's slow, but it's not horrifically slow. And the artery vein time, assuming this is a live video, is not horrifically slow. So it's slow, but it's not definite ocular ischemic
right.
type slow.
Right.
And with both eyes, we're not seeing overt vasculitis within the retinal vessels themselves, or you mentioned TREX as well. So there's not enough clues within the eye itself suggesting an overt vasculitic process in the retinal vessels. The transit time is not slow enough, you definitely throw your hat on that, but it's not quite anything, so therefore you have to stand back and do everything. The carotid Doppler doesn't fully exclude ocular ischemic syndrome. So if you have stenosis at the base or at the skull base, you'd miss it. And so if you still felt that was a possibility, you would need to do additional imaging and a CTA as well.
If I can mention, I mean, if this is truly ANCA positive, this is worrisome. So if this patient's ANCA positive with now a second RVO, I mean, I would say that some of those veins are leaking, certainly could be from the vein occlusion, but if he's had previous renal issues, this is danger for this patient. So I would highly immune suppress this patient and start them probably on systemic immunosuppressives. And usually in our institution, I would use anti-B cell. We would use rituximab for someone like this. This is on its way. I would be very, very concerned about this eye.
Would you have done that after the first eye?
Yeah, I mean, one ANCA positive, if it's a true ANCA and it's in the spectrum of GPA, and it sounds like he had renal disease, those patients start on rituximab for us and stay on it for a very long time.
All right.
So what's the mechanism in the eye?
So it's hard to know. I think it's speculation. Is it a vasculitis or is it an occlusive? I think of this as a combination because I still think that some of these patients have sinus issues that you don't actually identify, and they have a vasculitis within the sinus in the orbit, and that's what causes the perfusion change. So you have to really look for it in order to find it, but this is not unusual to see one eye go and then a few years later the other eye start to come in ANCA patients. So this is something that's very concerning.
Thank you, thank you. So now we go further, and we did what you said. That is now 2 months ago. So we gave him rituximab, and we gave him bevacizumab monthly, and started a high-dose short-course prednisone. And then he came back, and it looked better. I mean, you see at the veins there's less tortuosity. Everything is clearer. The retina is flattening down, but a little bit too much because there was quite a lot of ischemia already. And so we decided to go on. Rituximab is already in, and then he comes back. At that time we also made the fluorescein angiogram. It looks like this.
Yeah, it's worse.
So although the whole aspect is much more quiet, the flow seems to be less than at the start, isn't it?
Yeah, so the OCT is better, the flow is worse.
Yeah. Yeah.
It looks like a hypervicosity retinopathy, but you wouldn't expect that in one eye first and then later in the other eye. But that's basically, it looks like there's something wrong in the vessels.
If you share your thoughts, it would be wonderful. You've got some great ideas, so if you share them.
I just said that feeling phase was a little bit strange because there was some pulsation.
Yeah.
If there's an abstraction, I mean, I'm now sure. Probably I will do some imaging system for the. I will worry about brain or the other things. Probably there will be more complications for this patient.
All right. And then we saw him 2 days ago. These are the late frames. So we continued the bevacizumab. Rituximab was of course continued because it was already in there. The prednisone had already been tapered off, and he came 1 week too late for his intravitreal injection. It looked like this.
Terrible.
Yeah, this is unfortunate. I think, with the last one and this one, even though they're on rituximab, it's not universal. A lot of these patients need high-dose corticosteroids for a long period of time in order to control them. I would IV pulse this patient now, and they probably need to be on some additional immunosuppressive agents. It might be too late. Unfortunately, it looks like the perfusion's almost done. What's their renal function like? Is it okay?
The renal function is abnormal but stable, but already for years. And there was no systemic activity of the ANCA.
So the diagnosis, original presentation was renal blood pressure. What was the original? How was the original diagnosis made? How did they present? Or renal failure in a biopsy?
I haven't made I haven't made a diagnosis, so we are at this point.
We can do a wrap up now, sort of how far we got. I think we've heard ANCA-associated ischemic retinal vasculopathy, unknown mechanism, one eye first, other eye. If you see this ever, throw everything out at them, right? That you got for immunosuppression. I think that's what we learned. Is anyone want to add to this?
Sorry, one last comment there. Suspicion of. So you're basically feeling that we haven't got to the bottom of this yet, or making an assumption the ANCA explains everything. I think we're all a little unnerved by this so far. And maybe you'll come to part 2 next year and give us the full answers for this challenging case.
Hopefully.
Okay, thank you.
Hopefully. Thank you very much.
So we have a guest from the